Hello, and welcome to another Facebook Live broadcast with MedStar Georgetown University Hospital. My name is Mashan Bowman-Carter, and today I'm joined by two of our physicians, neurologist Dr. Benjamin Osborne. He's the director of the Neuromyelitis Optica and Neuro-Ophthalmology Clinics, as well as the director of the Multiple Sclerosis Fellowship Program, and also neurologist Dr. Robert Shin. He's the director of the Georgetown Multiple Sclerosis and Neuroimmunology Center. Today, we're going to discuss a rare inflammatory disorder called neuromyelitis optica spectrum disorder, also known as NMOSD. It affects around 15,000 Americans, and its symptoms include blurred vision or blindness, bladder or bowel dysfunction, painful muscle spasms, nausea, and numbness throughout the body. Our panel will share how they work with patients to provide the best medical care to manage the disease and achieve a better quality of life. So if you'd like to learn more, stick around, share this broadcast with your friends, give us a like to let us know that you're here, and share your comments and questions below. We're going to take some time to answer those as well. So before we dive into our questions, I want to direct it to Dr. Osborne and Dr. Shin. Thank you so much and welcome. Thanks for joining us. Before we dive into our questions, could you tell our viewers a little bit about yourself? I'll start with Dr. Osborne.
Sure. Hi, thanks for organizing this and setting this up. So I've been at Georgetown Hospital since 2006. I actually did a fellowship in neuro-ophthalmology, and during my fellowship, I spent half a day a week in the MS clinic and ended up seeing patients with MS. And that led to my interest in also seeing patients with optic neuritis and NMOSD. And so I'm looking forward to giving more information on this talk.
Thank you. Dr. Shin?
Well, like Dr. Osborne, I also have training in neuro-ophthalmology, or the neurology of vision. And then I also did a year of training in multiple sclerosis and neuroimmunology. And back then, actually, we didn't realize that MS and NMO were different disorders. But there's been a tremendous amount of progress in our understanding of NMO, as well as treatment options, as we'll be discussing. So I'm really excited to be here.
Awesome. Thank you both for joining us. And thank you for your time. So let's get started with our questions. So Dr. Osborne, could you explain what neuromyelitis optica spectrum disorder is? Or I know it's a long term, it sounds complicated. Could you just elaborate further on that and also share what are some of the most common symptoms that are seen at diagnosis?
Sure. So NMOSD, or neuromyelitis optica spectrum disorder, or sometimes it's just called NMO because that's shorter. It used to be known as Devick's disease because Devick was a neurologist who in the 19th century described patients, one particular patient who had bilateral vision loss and weakness, and basically found inflammation in the optic nerves in the spinal cord. So these patients typically have what's called an autoimmune disease. The immune system normally fights off infections, but in this case, it's kind of switched sides and is damaging the person's body. In particular, the optic nerves, which connect your eye to the brain, and the spinal cord, which connects the nerves from the brain to your arms and legs and bladder, can be damaged by the immune system. And so this damage can cause a variety of symptoms, but with vision loss, it's typically painful vision loss, although it might be painless in some cases. And it usually comes on over a period of hours to days. And in NMO in particular, it can be quite severe vision loss in one or both eyes. And the inflammation of the spinal cord can lead to weakness or numbness in the arms or legs. So somebody might come in with, in a wheelchair sometimes because the weakness is so profound. And so we treat these autoimmune diseases with medications that suppress the immune system. So if somebody comes in and they have optic neuritis or transverse myelitis, we'll typically work them up to try to figure out what's causing this. NMO is not the most common cause of optic neuritis or transverse myelitis. By far, MS would be a much more common disease that we'd look for. But some patients get misdiagnosed as MS, and then we figure out later it's NMO. So based on their MRI findings and then blood work, we can figure out whether they have MS or NMO. The MRI is very, very helpful because sometimes we'll see inflammation in the optic nerve that's quite extensive. There's particular parts of the optic nerve that might be more commonly involved. And same thing in the spinal cord. If you look at the MRI of somebody with NMO who's had inflammation in the spine, we might see a large segment of the spinal cord showing inflammation. Whereas with MS, they can have inflammation in the spinal cord, but it's usually much smaller segments of the spinal cord that are involved. So MRI is very helpful in trying to figure out the diagnosis. And we have blood work now that we can send off to help make the diagnosis also, because there are antibodies that we can detect in the blood that can help confirm if we suspect somebody has NMOSD.
Thank you very much for sharing that. Dr. Shin, could you further explain and elaborate the difference between multiple sclerosis and NMO?
Sure. It's actually challenging to do that because, as I said, for a long time, it was hard for us to recognize that they were actually two different disorders. But for a long time, we had recognized that sometimes people that we thought might have multiple sclerosis would have a different presentation where they might, as Dr. Osborne said, lose vision in both eyes. So, maybe be completely blind or have very severe spinal cord inflammation. We call that transverse myelitis. And when we saw that picture where the optic nerves and the spinal cord were affected, and sometimes in those individuals, the brain would be completely otherwise unaffected, that was recognized as neuromyelitis optica. So neuromyelitis, that myelitis means inflammation in the spinal cord, and optica having to do with vision and the optic nerves. Interestingly, I'm Korean actually. So it was also known that in Asia, East Asia, so Koreans, Chinese, Japanese people, we observed that when people in East Asia had multiple sclerosis, they often had it predominantly affecting the optic nerves and spinal cord. And we talked about something we call opticospinal MS or Asian MS. What changed in the early 2000s, and again, Dr. Osborne hinted at this, was a recognition that you can find an antibody in the blood to something we call aquaporin 4. So aquaporin means water channel, aquaporin. So antibodies against this water channel that's on a certain cell in the central nervous system called astrocytes turns out to be the marker for NMO. And what we realize is, actually, NMO is like the spectrum because it turned out Asian MS, opticospinal MS that's NMO. And it turned out that what we used to think was MS, but a variation with the optic nerves and spinal cord without affecting the brain, that's NMO. And then we discovered that there's actually other presentations. Sometimes there are brain lesions. Sometimes patients will actually present kind of weirdly with nausea or hiccups, like you would think it's a stomach disorder, but it turns out there's inflammation in the brainstem. So it turns out NMO or DeVick's disease had a spectrum. And so telling them apart is part of, to be honest, the challenge that Dr. Osborne and I have every day seeing individuals. And part of the reason for this Facebook Live presentation is to get the awareness out there that it is a distinct condition and it's important for us to figure that out.
Thank you very much. Yes, I agree. It is very important to get this information out there. I admit I had never heard of this disease. I was surprised to find out that it's often confused and sometimes misdiagnosed as MS. So it's very important to figure out and target what is going on and exactly what the condition is. So thank you very much for elaborating on that.
Sure.
So Dr. Osborne, could you share how NMOSD is diagnosed?
So we make the diagnosis based on criteria that have been described. Again, typically patients either have to have optic neuritis, transverse myelitis, so that's again either painful vision loss or extensive inflammation of the spinal cord. They might have this thing called an area postrema syndrome that Dr. Shin was describing, where patients have intractable nausea, vomiting, and hiccups. I actually had a visit today, a follow-up visit with one of my patients. That was her initial presentation. She had intractable nausea, vomiting, and hiccups going on for several weeks. And the GI doctors couldn't figure out there was no infection. She had an extensive workup. And then she eventually, an astute doctor tested her blood for something called the aquaporin 4 antibody, and she had a positive antibody. So about 80% of patients with NMOSD will have this antibody in their blood. So it's important when we draw the blood tests that we know which lab patients are getting the blood sent to, because sometimes the blood test comes back negative, but it might not have been the most reliable test. There's been different generations of blood tests that have been developed. So fortunately at Georgetown, we're able to send blood samples for patients who we suspect have NMO to an outside lab at the Mayo Clinic. And they have one of the best assays It's called a cell-based assay. Some of the older tests are called ELISAs. It's not important everybody knows the names of these, but your doctors should know what kind of tests they're sending off. Sometimes we suspect somebody has NMO, they have a classic presentation, but their blood test comes back negative. And we might repeat it 6, 12 months later. And the second time we send the test, it might come back positive. So those can be very helpful in making the diagnosis. I mentioned earlier that we have to review the MRI scans because there could be findings on the MRI that help confirm the diagnosis also. So if we see findings in parts of the brain where we typically see inflammation that's more characteristic of NMO, that will lead us towards that diagnosis versus MS. Although to be honest, sometimes it's hard to make that distinction in some cases. Sometimes we'll also switch tests for other diseases that can mimic MS and NMO. So there's another disease called MOG, which if patients don't have aquaporin 4 antibodies, there's another blood test that we can send for called MOG, MOG, which is a similar disease in some respects. It can cause optic neuritis. It can cause inflammation in the spinal cord. Has a predilection sometimes more for pediatric patients. And so we can test for that also, and that can help make the diagnosis of what we call MOGAD or MOG-associated disease. And all these diseases, MS, NMO, and MOG, have slightly different treatment options. And so that's why it's one of the important reasons we make the distinction between those different diseases.
Perfect. Thank you very much for explaining that, Dr. Osborne. And thank you for joining us today. I'd like to welcome our viewers again. If you're just joining us, I'm joined by neurologist Dr. Benjamin Osborne and Dr. Robert Shin. We're discussing a rare inflammatory disorder called neuromyelitis optica spectrum disorder, also called NMO, NMOSD. So far, we've defined what it is, common symptoms, how it's diagnosed, but we have more to talk about. So keep watching, share this broadcast with your friends, give us a like to let us know that you're here and you're watching, and share your questions with us in the comments below. We're going to take some time to answer those as well. So let's continue with some questions. I'd like to know, is NMO hereditary? Can it be passed down?
Sure. So NMO typically is not hereditary. So we don't typically do screening of first-degree relatives. Most of the times it's sporadic. So there are patients who rarely have another family member with autoimmune diseases. That is a little bit more common. So once a patient has one autoimmune disease like NMOSD, if we do a detailed family history, we might find out that they have a cousin with lupus, or one of their parents has Crohn's disease or Sjogren's disease. These are all different autoimmune diseases, but in general, there's no genetic testing to screen for it. We don't recommend screening first-degree relatives.
Thank you very much. Dr. Shin, how will a patient know if they're having an NMO attack? What does that look like? And are there any signs that someone should be aware of?
Sure, that's a great question. We've already hinted at some of the more common presentations. So if there's inflammation of the optic nerves, or we call that optic neuritis, people can have loss of vision. It might be one eye, but sometimes it's both eyes. Sometimes someone will lose vision completely if both optic nerves or the connection of the optic nerves, we call it the chiasm, are involved. So in that situation, it's not hard to notice. You lose vision in one or both eyes. As Dr. Osborne mentioned, it can be painful. It doesn't have to be, but you can have discomfort as well. The other big presentation that, again, we've mentioned a few times is if your spinal cord gets inflammation. Now, what would that be like? Well, the spinal cord is like a cable from your brain down into your back. So it could cause leg weakness, maybe arm and leg weakness, loss of balance, loss of bladder control. There could be numbness. There can be even a squeezing feeling across the torso or chest. So again, not usually something that would be subtle, something that you'd be like, hey, something is going on here. I'm having trouble walking. I'm losing some strength here. And then again, as Dr. Osborne mentioned, you can even have this area postrema syndrome. That's a part of the brain that controls things like nausea. So it actually is the case you just mentioned, feeling sick to your stomach, having this nausea and vomiting, maybe hiccups that won't go away. And, there doesn't seem to be any cause for that. And to be honest, there are others, so those are just some of the presentations. But it's usually something that would definitely make you think, hey, something's going on here. And I guess the key is to make sure that people know that you need to go see a neurologist, and get these kinds of things checked out.
Absolutely. Thank you very much. Dr. Osborne, related to my last question to Dr. Shin, can someone recover from an NMO attack? Is there a possibility of, somehow treating or reversing the blindness or treating the nausea, any of the other symptoms that come along with that attack?
Absolutely. So there is definitely a risk of permanent disability with NMO attacks, and some patients have incomplete or poor recovery, but not an insignificant number of patients, once it's recognized they have NMO, can have good recovery. We talk about in the world of stroke, time is brain, and I think a lot of people recognize the same thing with NMOSD relapses. So the sooner somebody recognizes that it's an NMOSD attack or relapse, we can initiate treatment with IV steroids. High doses of steroids are usually administered in the hospital. And then sometimes patients also need to get something called plasmapheresis or plasma exchange. This is a little bit more of an invasive procedure, but basically the person's blood is filtered out, and what they remove are some of the inflammatory proteins in the blood, like the aquaporin 4 antibody and other parts of the immune system called complement. They get filtered out during plasmapheresis and help the body recover from the relapse. And then after a patient gets maybe IV steroids alone or IV steroids followed by plasmapheresis, or this PLEX, we abbreviate it, if it's a severe attack that caused them to have weakness in their arms or legs, they might get discharged to a rehab facility. And physical therapy can be very important for the recovery after some of these attacks. So, some patients might end up in the hospital unable to initially walk or using a walker. And then as they recover, they'll graduate maybe to a cane, and then maybe not even needing a cane. Recovery can take a long time, though. In some cases, they might have the attack come on with a period of hours to days, and then it could take weeks or months to fully reach the peak recovery. So unfortunately, the recovery, you have to have some patience.
Maybe I could add also, if it's all right, that and I think if people are trying to read up on NMOSD more, sometimes you'll read things saying that NMO attacks are hard to recover from, or that sometimes there's no real recovery. And I do have to admit, of course, that is possible. But I think Dr. Osborne and I, both have seen cases where people can have excellent recovery. And I think maybe like many other neurological conditions, the earlier we can figure out what's going on and the sooner we can get them on an effective therapy, whether it's things like corticosteroids to reduce the inflammation or plasma exchange, the better people can do. And I've definitely seen full recovery when we can get to people in time. And, one other point I wanted to add, which I realize we probably haven't said yet, but I think is very important. For a long time, NMO was not thought to be a treatable condition, but in the past several years, the field has made tremendous breakthroughs, and there are now actually 3 different FDA-approved treatment options, not so much to treat the episodes or attacks of NMO, but to prevent them from happening into the future. And so, if I can just mention them briefly, but we have eculizumab or Soliris, which was the first FDA-approved treatment for NMO spectrum disorder. But we also have inebilizumab or Uplizna, which was the second FDA-approved treatment for NMO spectrum disorder. And we even have satralizumab or Enspryng. So we now have 3 different treatments that are FDA approved for NMO spectrum disorder. So again, reinforcing maybe to your point that how important it is for us to get the word out that this condition exists, that it's different from MS, that it's treatable if we can make the diagnosis as soon as possible.
Absolutely. Thank you very much. Valuable information being shared by the both of you. I really appreciate your help in getting the word out about this condition. And thank you for sharing your expertise with us. So lastly, as we close, I have a question for Dr. Osborne. What do you most want people to take away from our conversation today?
I think just reiterate what Dr. Shin just said. We've made astounding progress in the treatment of NMOSD from just in 2006, recognizing that's approximately when we started to recognize that it's a different disease from MS, to today, where we now, just in the span of just 2 years or less, having 3 FDA-approved therapies for treating this disease. And so we've really made amazing strides in recognizing what this disease is and how to treat it. And so it's an amazing time that we live in. As much as it can be scary to get diagnosed with a autoimmune disease that can cause significant problems with disability, potential blindness, I think it's also a time of hope and quite a great bit of excitement that we have these different treatment options for patients.
Absolutely. Dr. Shin, would you like to say something as well?
No, I think Dr. Osborne said it really well. The key is for all of us to recognize NMO and to diagnose it as soon as possible to take advantage of the advances that Dr. Osborne just mentioned.
Absolutely. Thank you both. That wraps up our broadcast. I'd like to thank our speakers, Dr. Osborne, Dr. Shin, for taking the time to join us this evening and share such valuable information. And thanks to all of our viewers out there for tuning in. We really enjoy connecting with you, and we hope that you found this a good resource for you and your journey to good health. So if you or loved one has been affected by NMOSD and would like to schedule an appointment, please call 202-295-0540, or you can visit our website for more information. We're going to share both the phone number and the webpage as well for you to learn more. And we will see you next time. Bye.
Good night.